Okay, let's let her rip here. Okay, so we have that patient who is allergic to insect stings. You referred her to get allergy tests and that sort of thing, and so she was allergic to some insect venoms, and so you referred her for immunotherapy. So you get the shots going, and she's doing okay. She did the first vial in your shots without reaction, to let the silver vial, the 1 to 10,000. On the first shot from the second vial, she develops generalized hives, facial swelling, and cough within 4 minutes. Oh, and you have a full schedule, and your partner decided to take 3 weeks vacation because he was so happy that you showed up, and he finally has a partner, and you just hired a new LPN last week, just the perfect storm, right? And so you see this patient, and you got to think to yourself, what are the first thoughts that are going to come to your mind? And I want you to think about it now. I want you to take 10 seconds to think about it now, because this is a situation that you're probably going to encounter sometime in this hospital or in your practice or that sort of thing. And so kind of going through the mental deliberate practice ahead, I think, would be a benefit. And it's my job here for you to be very comfortable how to respond to a situation like this. So that is really my primary goal for this lecture. And if we don't talk about anything else, and I can't talk about chronic urticaria in the last hour, I really want to make sure that we nail it cold, all right? So again, this is the story. You see this patient. What are you thinking, and what will you do first, all right? And the reason I ask that question, what do you do first, is that the clock just started, and the clock is ticking, okay? So the learning objective for this talk is I really want you to be very able to do a rapid assessment on a patient who presents like this, so you know the criteria for anaphylaxis, that you know why it's happening. I'm sorry, as an immunologist, we just cannot get over the whole little cells and the IgE. We like that stuff. I apologize. All right. What can mimic this condition? How to take a good history after it happens? You can take a deep breath. Right. But I want you to be able to treat that reaction, evaluate, treat it appropriately, and then we'll talk about hives if we get to it. All right. So, question 1. I told you it was coming. So, you were concerned about anaphylaxis. It's a young woman. I apologize. You're going to do that rapid assessment. What are the findings you think is not relevant to anaphylaxis? Runny nose, vomiting, itching, or flushing, or all of the above is consistent. Go ahead. And I know there's at least 12 people with clickers. So, hopefully we can be 12. Let's get 15. Okay, we're at 10, 15. Yes, there we go. All right. What do we say here? Oh my goodness, that's incredibly annoying. All right, so some of you guys threw out runny nose. Some of you guys threw out vomiting. Some of you guys think flushing is bogus. But a lot of you seem to suggest that everything is important information. And I would agree with that. So, anaphylaxis. Anaphylaxis is a severe, life-threatening allergic reaction, all right? And why am I making a big deal about it? Because it is rapidly progressive. So studies have shown that an insect sting can cause death within 15 minutes. A food reaction can cause death within 30 minutes. The clock is ticking. So rapid assessment and initiative treatment is very essential for this type of patient. And so that is the one of the take-home messages I really wanted to bring from this talk. And so what is your rapid assessment? And it's really under 4 major organ systems. Number 1 is cutaneous. Cutaneous is the most common the most common symptom and sign of an anaphylactic reaction, with urticaria and angioedema being seen in 85 to 90% of patients. So, you could take the converse of that, is that if someone comes in saying a recurrent anaphylaxis and they don't have a cutaneous sign, a rash, I'm not saying that they didn't have anaphylaxis, but you might want to consider an alternative diagnosis, just because it's so common, all right? It doesn't exclude anaphylaxis, but just think about it, keep your mind open in that sort of situation. Flushing is very relevant. You don't really have to have rash. You get a pruritus. That's in a minority of patients. Second thing is respiratory. Respiratory is obviously the things we worry about. No one thought wheezing was irrelevant, right? So dyspnea, wheeze, bronchospasm, upper airway edema, laryngospasm, that sort of thing. And then I threw it in there, rhinitis. Yes, so think of the worst, allergies you ever seen with running, the nose is running and the eyes are watering. Very relevant to anaphylaxis. Cardiovascular, dizziness, syncope, hypotension. That's the most serious thing. We know the patient's in deep trouble when they drop their blood pressure or they start feeling faint, right? Now, abdominal is also is less recognized, but certainly you could have angioedema of the bowel, you could have vomiting, cramping, you could have actually extravasation of fluid and diarrhea. And that's seen as about a quarter of these anaphylactic reactions. Other miscellaneous stuff would be headache, substernal pain, seizure, uterine cramps has been described. That's more abdominal pain, obviously. But remember these systems: skin, respiratory, gastrointestinal, and cardiovascular. All right? So you're going to assess those organ systems. And in addition to their hives and edema and cough, she is also having a vomiting and abdominal pain. She has no lip and tongue edema, no wheezing or stridor, no throat symptoms, no rhinitis. Lung sounds are great. Blood pressure is solid. Sorry, my bad. Very simple question. Does she have anaphylaxis? Yes or no? Fifteen is the magic number. Okay, never mind. Okay, I'll let you out there. Okay, let's see. So survey says, okay, we're about 8 versus 5 here. Okay, so the majority says yes, but there's a large minority says does not make the criteria yet. So let's look at it. What is the criteria? Okay, so clinical criteria for anaphylaxis. 3 major criteria. Number 1, if a patient has acute onset of cutaneous symptoms and either respiratory or cardiovascular involvement, you don't need to know about an exposure, right? Exposure is irrelevant. Cutaneous plus respiratory or cardiovascular buys you anaphylaxis, all right? Number 2, 2 system organ involvement after exposure, all right? So what is our patient exposure? She got an allergy shot. She had cutaneous symptoms. She had gastrointestinal symptoms. She was coughing. I would count that as a respiratory system. Blood pressure was solid, all right? She had 3 organ system involvement. She has anaphylaxis, all right? So again, making that decision, anaphylaxis, yes or no, is definitely going to direct how you treat that patient, all right? So again, please take home message. This is the criteria for anaphylaxis. This is the organ systems you're supposed to identify. Once you make the diagnosis of anaphylaxis, treatment must be started immediately, okay? Last one, cardiovascular. If you know the patient had, peanut, drops his blood pressure, who cares about the blood, who cares about runny nose, who cares about GI, the patient dropped his pressure and was exposed to something they were allergic to, that patient must be treated, all right? You're not going to just kind of wait around, let's just see if they kind of get wheezing. You're going to, the pressure's 70 over 40, you're going to do something about it, all right? Okay, what is the kind of, I gave you a very specific case on immunotherapy, but, let's just kind of open the box. You're going to try to, you're going to treat that patient, but let's kind of think about what are the triggers that I'm implying in the clinical criteria. Well, food is a very common trigger, right? Peanut, is the one we think about, but there's certainly, you can think of any food could be triggering an allergic reaction. Now, interestingly, a lot of idiopathic anaphylaxis has been associated with a delayed reaction to animal meats, particularly beef, pork and lamb. This has just been kind of discovered in the last 2 to 3 years. And so, like I said, the standard dogma is that the exposure for food, it has to be within like a couple hours or that sort of thing. Well, there has been described syndromes where someone's had beef maybe 6, 8 hours later and then developed anaphylaxis, nowhere near to the time of the meal. And it's really thought to be due to not the protein itself, but actually the sugars coating the protein. As you know, we are not pigs. We are not cows, right? Our body metabolizes things different than animals. And therefore, that is an opportunity for us to get sensitized to those things, all right? Delayed reaction, no prior exposure. I would ask about what they ate last night, all right? Medications. So, we give transfusions, contrast media, can be nonspecific, so it could be confusing. Or, you got that Zosyn infusion, whatever, definitely fair game. Latex. Most hospitals are latex-free. Certainly the patient who has had multiple surgeries at higher risk for latex exposure. Stinging insects I mentioned. Occupational exposures are certainly fair game. Now the rare stuff. So rare stuff could include food, exercise. There's actually food associated with exercise where certain foods then exercise bother them instead of exercise alone. Think of all the permutations that's out there. And then the most dreaded for the allergist is idiopathic. It's either we're too dumb to figure it out, or it really is just kind of dumb. And we hope, there's actually clinical trials looking at Xolair for this population. Darn it, the same slide, all right? I'm going to go through it. I really already talked about it, but I'm really going to emphasize we're talking about a systemic reaction where the gun went off, right? This patient has a systemic load of all the mast cells releasing all the horrific stuff out there. It's going to affect smooth muscles, bronchoconstriction. You're going to get vasodilation and leaky vessels. Mucus production, I talked about rhinitis. Certainly you're going to get itching, eosinophilia, that sort of thing, right? And so you go from this to this. The gun goes off, all the granules release, all this stuff is related. Your body has a huge load of vasoactive substances, and then you have systemic symptoms from it, all right? And so, certainly this can happen. We think of IgE as the responder. I told you about IgE bristling on the outside of these mast cells. If you bring in the peanut or whatever, you get a cross-linking of these two IgEs together, and boom, right? You empty out everything. Now, certain things can do this without the presence of IgE. You don't have to actually be sensitized by IgE antibody to have this occur. The usual things that can do this is exercise, contrast media, certain drugs. We all know Red Man's, right? Red Man's, loves to set off those mast cells if you give it fast enough. Opiates, COX-1 inhibitors, and then the really fun stuff that's really kind of, fun to allergists, I'm sorry. That's really rare, UV radiation, heat, cold, that sort of thing. So look at all this stuff. Mast cells are full of really bad stuff, right? The one we always worry about is histamine, right? Histamine does all the things I talked about on smooth muscle, on vessels and nerves and that sort of thing. But I really want to bring your attention to, to tryptase, all right? So tryptase, so histamine, the half-life of histamine is so short that 60 minutes after the reaction, your histamine is all gone, all right? So, histamine is a very poor marker for mast cell degranulation. So we really depend on the tryptase, which is an enzyme that kind of peaks around 30 minutes, maybe lasts around 6 hours. I've seen patients have positive tryptase 12 hours after the reaction. More helpful if it's positive, not very helpful if it's negative. But certainly this is something I want you to keep in the back of your mind, that tryptase is a marker for anaphylaxis. That is a blood test for you to confirm that diagnosis if it is questionable. So again, mast cell granule release, GI symptoms, airway symptoms, blood vessels, all these sorts of horrible things. Why does it do this? Why do we have a system that causes all these horrible symptoms? Worms, all right? So we grew up with worms. We were, worms are all over the place. Parasites, whatever. Well, we got to get rid of these guys. So you get diarrhea, expulsion of the content, vomiting, diarrhea. You get rid of the worms that way. a lot of worms are in the airway. We try to kind of, make it phlegmy, make it a hostile environment to them. We bring in eosinophils to kill these guys. The whole foundation of this mast cell response is protection against parasites, but is an inappropriate reaction to whatever allergen is. The immune system is confused, okay? So there are other things that can mimic anaphylaxis. And certainly, if you have a single organ system, you'd have like urticaria by itself, asthma by itself, blood pressure type symptoms by itself, shock or, syncope, that sort of thing. But there's actually histamine-related conditions. So one is if you have a mast cell tumor, right? If you have too many mast cells in the body, you could have potentially a large mast cell load by exogenous production. Some patients might have just a large, mastocytoma or urticaria pigmentosa, which is a clump of mast cells, and then sometimes stroking that can cause a systemic release of histamine. Certain leukemias are associated with endogenous histamine production. Other things include ingestion syndromes, like some people flush with MSG. If I had a patient who went to like the local farmer's market, got some wahoo fish. It was probably really, really, really old. Bacteria cranked out some bad vasoactive substances. They ate the histamine, got hives after the fish, was not allergic to fish. So seen with tuna, that sort of thing. Flushing disorders. Carcinoid, very rare. We know red man syndrome with vancomycin. If you're Asian like me, you get very pink. Rare stuff, medullary carcinoma of the thyroid, that sort of thing. I'll talk about angioedema later. Pheo, yes, it's hypertension. Sometimes you can have a paradoxical hypotension with that. And then we always put psych on the bottom here, like panic attack, that sort of thing. All right? It's just, you don't have to memorize. I just want you to know that there are alternative diagnoses. And so you just want to keep your mind open about certain things sometimes, all right? So I know I just couldn't resist coming attractions. Allergic angioedema is not hereditary angioedema. They are two different conditions, all right? So when I say allergic angioedema, I told you that mechanism is a mast cell mediated process with the gun going off and histamine being released, all right? So it is a mast cell mediated activation, all right? So this would be a rapid type onset. It would happen more quickly after the exposure. Itching, again, histamine works on nerves. Itching is a very prominent symptom. If you have cutaneous, which is an 85 to 90% of of anaphylactic reactions, usually get hives as well. And then, so you want to treat the underlying cause with stopping histamine, giving epi, shut down, gene transcription, all right? Hereditary angioedema is a immune deficiency, right? It is a disorder of complement, all right? It is not a mast cell mediated process, and so inappropriate metabolism of the contact system, which I'll get to later, is going to release bradykinin. Bradykinin can do a lot of things histamine does. It can make vessels leaky, that sort of thing, and you get the angioedema associated with that. And it's due because of this C1 inhibitor usually puts the brakes on complement activation, but is not able to do it because of a problem with either function or level. So this is more of a steady process. Again, this is more rapid. This is more of kind of a progressive, slower onset, but kind of slow but steady. So the rash. So I mentioned hives, urticaria, and allergic angioedema. Hereditary angioedema can have a rash, but it's more of a serpiginous erythema marginatum type rash, and it is non-pruritic. So again, the nature of the rash is going to really kind of determine these two conditions. So I mentioned abdominal pain is a feature of anaphylaxis. If you have intestinal edema, you can get vomiting and intestinal swelling. So like I said, I don't want you to get confused. There are intestinal symptoms that are prominent in hereditary angioedema attacks that can mimic some features of anaphylaxis. And again, you are not treating mast cells. You're not giving antihistamines or epi for this. You are treating the problem, which is deficiency in the C1 inhibitor and overactivation of the contact system. So we'll get this later. And so this is coming attractions. I just couldn't resist. I just want to plant the seed. We'll talk about it a little bit later. All right, question 3. We make the diagnosis of anaphylaxis. She's 70 kilos. What is the initial therapy? Benadryl 50, 1 to 1,000 of epi intramuscular, 1 to 1,000 epi subcutaneous, 60 of prednisone, normal saline, 1 liter bolus. Go for it. Anyone else? All right. I'm just going to accept the 13 for now. All right, that's fine. Thanks, guys. So survey says, so a couple of people say Benadryl, and they were kind of split between intramuscular and subcutaneous. All right, so I'm really, really, really glad you guys say epi. Epi, 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 right? You know, I mean, if you look at the big picture, if vomiting and intestinal problems is related to the diagnosis of anaphylaxis, oral medications is not going to do the job here, all right? You really want to give something systemic that's going to get into the blood system fast. You want something that's going to work fast and it's going to treat the problem fast, that is progressive, okay? So how are we going to manage these patients? So you make the diagnosis of anaphylaxis. I asked you the question, what is the first thing you're going to do? And the first thing you're going to do, you stick to the basics. You guys know the basics, and it's rapid assessment of airway, breathing, and circulation, the ABCs. And so, you want to see, is the airway clear? Are they having upper airway involvement? How is their breathing? How is their cardiovascular system? Are they mentating? Are they oriented? Is there suggestion of hypoperfusion? Cutaneous involvement? Have you assessed the 4 organ systems? Estimation of weight is probably more relevant to peds, but like I said, it's going to help with your dosing, right? If they're getting that blood transfusion or the drug, you probably want to stop the infusion. And then intramuscular. So why did I say intramuscular? So they've actually looked at subcutaneous versus intramuscular administration. They looked at the deltoid. They looked at the lateral thigh. Peak epinephrine dosing to the heart at the earliest time point occurred with intramuscular administration in the lateral thigh. All right? Again, 1 to 1,000 epinephrine, intramuscular, lateral thigh. Always. Okay? So you can repeat the 5 to 15 minutes, and that's going to get your quickest administration of the drug to where you need to give it. All right? Obviously, if you make this decision, you've already called for help. Recumbent position. So there is this kind of described empty ventricle syndrome where patients have received, are undergoing anaphylaxis. Maybe they got epi, they sit up, and they basically had cardiac arrest. All right. So we want the patient to be recumbent. Make sure the arm, the legs are at the level of the heart. Certainly, if you feel like you need to call anesthesia, you're going to call anesthesia. Right. That's part of your ABC. Oxygen. Circulation, you're going to make sure you have access. You might need it. And then now I'm going to talk about the medicines, right? So you're going to give either intravenous or oral antihistamines. You're going to give albuterol. You're going to give them corticosteroid. But remember, corticosteroid is a drug that's going to help you later, right? This corticosteroids is not going to help you now when the reaction is happening. So, if there's a delay in the solumedrol, I'm not going to cry about it. I'm going to focus on the stuff that's helping me now: the epi, the fluid, the antihistamines. Adjunctive medicine is also Zantac, ranitidine, or you probably get maybe like 10% more antihistamine benefit from that. But I would stick to the basics, with epi being the most important thing. Okay, I just I'm bringing this slide because it shows you a lot of differentials on lab tests you want to do, but again, tryptase is what's going to help you out. Why? If there's a question that this really was an anaphylactic reaction, if the tryptase is positive, then you know that mast cell activation occurred. For whatever reason, you know it was a mast cell mediated process. If it's negative, well, you don't know, right? Because sometimes the tryptase won't be elevated, even if you do have frank anaphylaxis. But if it's positive, then you are more secure that mast cells were involved in the reaction, all right? It's going to narrow your, that big differential diagnosis is going to really narrow your differential. So, how are we going to manage these patients? So, there is the kind of phenomenon that after the initial event, you can get a biphasic recurrence of symptoms 8 to 12 hours later. We're not sure why this happens, but again, they could get the hives, they could get the swelling, they could get other organ systems involved. So, anyone who has a pretty severe anaphylactic reaction should be rechecked for that second occurrence 8 to 12 hours later. And you should be aware, you admitted this patient to the ICU, you should, give the nurse the heads up. This patient could actually get a recurrence of symptoms, all right? The patient's not stable yet, all right? And, there's some thought that corticosteroids might blunt this reaction. Unfortunately, there's no controlled trials to state evidence for this, so just protect yourself and be aware of it. Certainly for discharge planning, hopefully you know what the trigger is, or you can kind of counsel the patient to avoid that trigger. You're going to tell them how to recognize the signs and symptoms of anaphylaxis. They might need an EpiPen auto-injector, and then also encourage them to seek help as soon as possible, because delayed administration of epinephrine is the single most cause for fatal reactions due to anaphylaxis. Again, EpiPen prescription and teaching, and then referral to allergists. So we're going to figure this out. Now, certainly, I'd prefer it to be 4 weeks later so we could reload the gun. Mast cells can be in a senescent state where if I skin tested them or whatever, I would get a negative test. You give the mast cells time to recharge. We depend on the mast cells for those positive skin tests that Tal showed you. So, like I said, that would help us out. Certainly, we can see them twice if you want to, but we're not going to test them really until about 1 month after the reaction. When we do test them, make sure they're not on antihistamines. First or second antihistamines like chlorpheniramine or Benadryl, Atarax, Zyrtec, Allegra, whatever, for various amounts of time can suppress the reaction. Claritin can suppress reactions as long as 7 days after the last pill. Certainly, tricyclics can also interfere with testing. Zantac seems to have a trivial effect, and this is less relevant to medicine, but EMLA suppresses the flare response, so you may want, we don't typically do that. So again, I really want to summarize this, and I'm going to break for questions actually in the middle of my talk, because I want to make sure that's very well, cemented. And again, anaphylaxis is a potentially fatal condition that can kill your patient in a rapid amount of time. 15 to 30 minutes could be the time you have to rapidly recognize the condition and initiate therapy. All right, so that's the main purpose of my talk. So therefore, prompt recognition and treatment is critical. Epi is the treatment of choice. 1 to 1,000, lateral thigh, intramuscular. Repeat 5 to 15 minutes if necessary. Epi doesn't kill anybody. They used to give Epi for asthma. Anaphylaxis is going to kill someone. Epi is not going to be the one. Epi doesn't make people feel very good, but like I said, you're going to save someone's life with that. There's very few situations where you feel like you're the one to save someone's life. This is probably one of those situations. All right. Again, shortness of breath, throat tightness, altered metastasis. Don't worry about it. If you give Epi, the worst thing you do is you gave them. You made them pretty nervous. You gave them a big adrenaline shot. I mean, that's the worst thing you did. All right. So I'm going to stop here. Any questions about the first part of this talk? All right. Sure. Yes, please.
Sometimes the term anaphylactoid is thrown around. Is that referring to a non-mast cell mediated mechanism?
It's actually more, to be more specifically, it's actually referring to a non-immunologic, all right? So when I mean immunologic, I really mean that the antibodies cross-linked on the mast cells and cause release of the granules. So anaphylactoid, which, like I said, we're trying to not use anymore, but just kind of set it on your mind, is that is a non-specific mast cell degranulation for whatever cause. So, you could say that, the opiates or the, I told you about Vang or, contrast media can cause degranulation of mast cells that doesn't involve the IgE and the cross-linking and all that stuff. All right, that's a great question. Thank you. Yes?
You mentioned about fish. Some people eat and get swelling of the lips and whatnot, and then they come to you. Should you advise them that it wasn't an allergy? They can go back to eating that kind of sushi if they want again?
Well, like I said, what we do is we test them. We're going to look for the IgE antibodies, and if we don't see it, it depends on the history. Is there a good history that this was rotten tuna that, didn't come in through UPS, but maybe, was sitting outside for a while. Maybe the guy's trying to make some bucks. Or, or is it kind of a weird history that's not consistent with scromboid? So, I think the way allergists would approach it is the history consistent? Is there presence of IgE? Then we do a risk assessment. If it sounds pretty straightforward, I think a lot of allergists would do what you're saying. Don't worry about it. If there's any question, we challenge that patient. We trust bring in the patient, give them the food, and see what happens. We have all the emergency meds. We have well-trained personnel. Food challenges we do in the office all the time. Any other questions? Everyone's pretty clear? Okay, like I said, this was the most important thing. If I spend the whole hour talking about it, I just want to make sure it was well. Okay, so let's talk about hives. Okay, so, stock photo, I'm sorry. Okay, we got a man here, and he's got rash and itching for weeks. Sometimes he gets swelling. No respiratory GI. It's basically a cutaneous reaction. Very itchy, very bothersome. He's changing his soap. He's, changed his laundry detergent. Even tried to fool around with his diet a little bit. And again, you're having a similar type of story, all right? There's less stuff, but now you're going to reformulate your approach to that patient because of some of the changes in the history. And like I said, I just want you to we're going to try to see how this differs from the previous case. Okay, so what's coming to your mind this time, and now what questions are you asking? Okay, so my first question is it hives? It's a stupid question, but hives means different things to different people, and actually hives is a very specific definition. And so when I mean hives, what do I mean? Okay, so hives itches, all right? Again, it's a histamine-mediated reaction. Histamine goes to the nerve cells, you itch, all right? So burning. Okay, so why did I put a burning here? So burning has been associated with urticaria associated with vasculitis, all right? So I'm not saying they have vasculitis if they burn with the rash, but certainly that is something that might, like I said, you get information. Does it follow the pattern, or is it kind of coming off the pattern? Burning with the rash kind of falls off the pattern, okay? Are they raised and swelling? So you get a lot of flat stuff or something like that. But, like I said, I like to get a nice history of, fluid extravasation, edema, and like a raised wheel or something like that. Again, doesn't just exclude hives, but like I said, you want to kind of look for a consistent history. As you can see, these are raised off the skin here. And is it erythematous that blanch with pressure, right? Again, I'm trying to make it distinguish with vasodilation versus actual vessel damage and bleeding, right? So, as we know, purpura, petechiae, that sort of thing, that's vessel damage that does not blanch with pressure. Something with vasodilation, because of histamine, you're going to have a nice blanching rash, right? So evanescent. I don't know why people use this term. Let's say what it is. They're transient hives, right? So hives, usually the lifespan of a hive, one hive from start to finish, is usually no more than 24 hours. Hives, that last like 48 hours or longer, you might want to consider alternate causes than traditional mast cell mediated hives. And do they resolve without a mark? Again, I talked about bruising. I talked about, capillary inflammation, residual bruising after resolution of hive is more suggestive of hypocomplementemic urticaria vasculitis. Angioedema, of course, you're going to ask. And then, again, I've been asking you about exposures, right? What are the exposures to event? Most exposures are immediate to the reaction. And so, you're going to see if there's a consistent exposure that is triggering the hives. Again, for your fun, urticaria comes from the stinging nettle plant. Stinging nettle has these beautiful hollow needles that are just loaded with serotonin and histamine that's going to give you problems. And so, you might want to ask if they've been exposed to stinging nettle. That would seal the diagnosis of urticaria. I don't think that's usually I've never met a patient who said that, but, now you know where it comes from. Of course, it has a burning sensation, so I guess I'm confusing myself now. Maybe I'm going to change this slide later. I apologize. Anyways, epi, right? So about a quarter of patients will have an episode of hives in their lifetime. How many of you guys have had hives before? I have had hives. Hives are very uncomfortable. They're itchy. They stink. It's not fun. All right? Now, there's this line we draw between acute hives and chronic hives, and it's that 6-week line. And that 6 weeks is very important because it changes your approach, it changes that prognosis for the patient. And so really you want to see, are they having acute urticaria or chronic urticaria? And so again, that 6-week cutoff drops that 25% to 0.3%. And this is kind of what we see in the clinic, that kind of persistent chronic hives doesn't seem to be going away. So here's question number 4. So you asked the questions I mentioned before. Sounds like hives. About 3 months ago. So we're past 6 weeks. This is chronic urticaria. Episodes seem to start at random. Tried to make an association. Can't seem a consistent prior exposure. He's worried about food allergy. What percentage of patients with chronic hives secondary to allergy to food? Go for it. Now I'm going for 13, right? That's the new cutoff. All right, there we go, 13. Survey says... All right, so we're all over the place here. Okay, so let's think about it. So a lot of you guys are clustering over food's not very likely and that sort of thing, and I actually agree with that a lot. And so let's kind of look at the statistics here. Okay, so basically the answer is under 2%, and so they've actually Alan Kaplan, when he was at the NIH, he's like one of the hives gurus. He threw all these hive patients on like lamb diets where they didn't eat anything except for one food, and basically no one got better. Lots of these patients. He's the kind of guy that he would say stuff like, "Yeah, I've treated 1,000 patients with hives, with chronic hives, and I've done the testing, and if you ask me how many patients actually had hives due to food allergy, his answer is 0." All right, it's probably not 0, but a lot of studies have kind of quoted the 1% to 2% range, if that. So what is the take-home message from this? Is that if you have the patient and you're not getting a clear exposure, right? This guy is not seeming to have any consistent exposure, meal, unmeal, not related to the meal, related to the meal, whatever. It's all over the place. Throw in a whole bunch of RAS tests. You check that box that says food allergen panel on your requisition or something like that. It's not going to give you the diagnosis. It's just not. It actually could cause a little problems. And the problem is that you could be avoiding stuff. You could be limiting your diet for no benefit. All right, and then you get a little confusion about labeling someone food allergy inappropriately. So comprehensive food allergy testing without a suggestive history is not indicated for chronic hives. Right? Take-home message. So what does cause this stuff? All right. Again, there's lots of stuff that can cause hives other than allergy. And if you have hives under 6 weeks of age, 80% of those are probably due to infection. All right, viral, bacterial, parasitic infections. Usually viral infections are very associated. So if you get that history of upper respiratory tract infection prior to the onset of hives, and it's been in that 6-week window, you have an explanation. You can't prove it, but you have a decent explanation. I mentioned IgE-mediated stuff, same triggers as anaphylaxis. I'm not going to belabor the point. We talked about non-immunologic triggers. This is the same stuff as anaphylaxis. We're talking about mast cell-mediated, histamine-mediated hives, right? So this is the fun stuff. Physical factors: scratching of the skin, cold, increase in core body temperature, exercise, pressure, UV radiation, vibration. The guy who runs the lawnmower, the jackhammer, or the string trimmer, right? So very interestingly, a very small subset of women have cyclical hives that correlate with the kind of rise in progesterone during their menstrual cycle. Some of these patients may be taking oral contraceptives at the time and maybe having problems with that. Autoimmune, like I said, autoimmune progesterone, urticaria is not very common. I mentioned vasculitis. I told you some kind of clues for that. Malignancy, we always worry about in the back of our mind, right? Again, a source of histamine. And then, again, we talk about idiopathic allergists, that's the most frustrating thing, that you don't have an answer, but we see this all the time, and we've learned to accept it because, thousands and thousands and thousands of patients have been tested for X, Y, and Z, and the majority of them have no clear 100% etiological trigger. Now, I'm going to talk a little bit about how we're kind of teasing this apart, but like I said, causation is, is a little, like I said, I think we're still working on it. So here's a nice artiste who has dermatographism. And so, like I said, scratching of the skin, usually I take a tongue blade, I kind of snap it. I'm not going for blood, I'm just going to scratch the skin. 15 minutes later, they get a welt, a linear welt where I scratch them, all right? Or you could be creative if you want. Cholinergic urticaria. So this is interesting. So cholinergic urticaria is hives triggered by an increase in core body temperature. The standard challenge is described as putting a patient in a 40-degree water bath, increasing their core body temperature by 0.7 degrees Celsius. All right. Now the hives are very distinctive. There's kind of like a background of flushing, and then they have very, very small pinpoint rash. All right. So if this happens after exercise, because you're going to get very heated if you're running out and it's like 100% humidity and 95 degrees, like it's been this summer, whatever, right? Flushing, small hives associated with either exercise or increase in heat, very suggestive of cholinergic urticaria. All right. Cold induced. So this is a patient I saw at Cincinnati Children's. She said she was having problems when she was driving and the window was down and cold air was blowing on her face. She was getting itching and rash in that area. I took one of those bags, I filled it with ice, I put it on her arm, walked away, came with my attending, and we saw this. We see this big wheal here that's raised and very itchy. You don't see the erythema very well. This is an iPhone camera, the iPhone 3G, sorry. But like I said, it's basically urticaria triggered by cold. And the ice cube challenge is kind of like the classic challenge for that. Sometimes you don't get to see this until it rewarms. If you see this, I would, in the back of your mind, you're going to think of possible causes for cold-induced urticaria. Things I would think about is things that can create cold-dependent antibodies, Hep C, mycoplasma. We know these conditions. Although also big time zebra, familiar cold autoinflammatory syndromes. The periodic fever syndromes. If someone has a problem history of fever or conjunctivitis, that sort of thing. But like I said, that's like big time zebra. I mean, I'm already throwing zebras at you. That's a big time zebra. So if we don't, how are we going to crack open that 75, 80% of idiopathic urticaria? Well, we have lots of ideas. Like I said, if the hives kind of happen like this, eventually it's going to overlap with a lot of stuff. All right, and so let's talk about some of these things. So I talked a little about food allergy. Elimination diets, some say, oh, it's 90% successful, some say 30% successful. But again, these were biased studies. They were not blinded, maybe a placebo effect. But if you do a double-blind, placebo-controlled food challenge, they cannot reproduce the symptom. If you think it's food allergy and they tried to give them the food on a blinded fashion, it did not reproduce the hives. Okay? Argues against food allergy. You might read a lot about case reports and meta-analysis looking at H. pylori. So H. pylori has an incidence of 0.5 to 1.5% of the population. And so it is way higher than that 0.3 I quoted for chronic hives. So as you can imagine, there's going to be some overlap between chronic hives and H. pylori infection of the gut. So some of these patients seem to get better when you eradicate H. pylori. Jury's still out on that. I think some allergists swear by this, some allergists don't buy it. But there hasn't been a control study to really definitively prove that H. pylori eradication can affect hives. But this is something you might see. Okay, so autoimmunity. So this is kind of like the more hot, up-and-coming explanation for hives. And the reason this is kind of important is that we think of hives as an external exposure triggering rash, right? That something external, I showed you that paradigm, right? That an allergen came in, cross-linked the IgE, released histamine. This, I'm positing that this is an alternative explanation, that you have an internal process that is auto-activating your mast cells. And what is that trigger is patient's own IgE, autoimmunity, either to its IgE receptor, either to IgE, but it in itself is causing the cross-linking required to cause mast cell degranulation. All right? Again, this is an internal trigger, not an external trigger. What are the evidence for this? Well, some allergists have taken patient's own serum, spun it down, took in blood, spun it down, took the serum, did a skin test, hives. Whale flare to their own serum. All right? And so there is obviously some sort of factor that seems to be in that serum that they seem to be reacting to. And there are more in vitro studies where they can look at activation of mast cells when you expose them to patient's serum, and they either see histamine release, you can see markers, like sometimes basophils, if they're activated, they express CD203 on their as a marker of basophil activation. There's multiple tests to kind of test to see if there's some sort of factor in the patient's serum that could be triggering this. But so what are we going to do for these patients who have chronic urticaria? Are we going to do nothing because it's idiopathic? Well, I mean, you're going to try to take a good history. You're going to try to go through those causes and see if you can see a consistent exposure. I mean, it may require a diary. It may require, a couple visits to kind of discuss it and that sort of thing. But, like I said, I think we should take an attempt to see if there's a consistent exposure. But if you're going to do that, like I said, you're going to do it directed by the history if you're going to test for it. Widespread skin, blood, everything on the laundry list rarely yields the etiologic agent. And I think, I'm really picking on food allergy here because as much as I'd love to have perfect testing, the positive predictive value of a positive skin test as low as 50%. I mean, if I took 100 people, all comers, and I tested them all to milk, of the patients who are positive to milk, if I actually gave them milk, half of them would be fine. So there's not a one-to-one correlation between a positive skin test and clinical allergy. It's two different categories: sensitization, presence of IgE, and actual clinical allergy, an actual reaction that you see. All right, and that's the caveat between widespread food allergy testing. You're not separating sensitization. You're not making the connection between sensitization and actual true causation of allergy. Okay. So many allergy specialists are going to do some testing though, and I'll tell you this is kind of some of the rationale we look at. We want to see if there's maybe some eosinophilia, there's some parasites going on, some malignancy going on. Maybe there's that, I'd mentioned hep C infection, or some infectious etiologies, viral infections. Is there any sniff of autoimmunity or vasculitis? And, we kind of look at autoimmune urticaria by either doing some of that skin tests or some of these fancy histamine release assays when we expose the patient's own serum to control basophils. Sometimes we kind of infer it, and this is obviously very loosey-goosey. I mean, like I said, I can imagine that myself would be skeptical about this, but you could make the argument that if you have an autoimmune tendency and make antibodies against your thyroid, that you are more likely to make other autoantibodies, and maybe you are kind of an autoimmune-ish type of person. Again, right, I'm doing this, a lot of this, but like I said, we kind of use this as phenotyping the patient, that is this an internal process or an externally triggered process, right? So acute urticaria, again, most of the time we find what the cause is, we remove the exposure, we treat them with antihistamines. This is a histamine-mediated process. We're going to treat them. We're going to block them with H1, H2. I like Zyrtec. You pick your poison. And then I usually kind of supplement it with an H2, right? I know it's a stomach medicine, Zantac, but it does block the H2 receptor. There's a little bit of a benefit. You maybe get a little extra boost there. You get breakthrough. You can give them a sedating antihistamine, and then if it's not working, you can give them a short course of steroids. You got to give them relief here, right? Long-term steroids, obviously, you better have an allergist involved. Sir.
And I'll just mention one thing. H2 blockers are also somewhat a little controversial even with allergists, because some of the early studies that were done that showed putative efficacy with H2 blockers was with Simenti, which had more of an impact on the P450 cycle.
Yeah, the metabolism.
And there was a thought that actually what he was doing was pushing up the serum levels of the antihistamine, because everybody who was in that study was already on an antihistamine. So, for example, David Kahn didn't actually believe in putting H2 blockers, but it depends on which allergist you talk to. So that's another thing.
Okay, that's where I was trained. I'm sorry. Sometimes you just do what they tell you to do, right? I'm sorry. Yeah. Okay. All right. So 6 weeks or later is chronic hives. Again, you're still going to stick to what works, and a large majority of patients can be managed on antihistamines. Now, they might require a lot of antihistamines. They may not respond to just 10 milligrams of Zyrtec. You might have to give them 4 times a day Atarax or something. There's concerns about sedation about that, but some of these patients can tolerate that dose. After a while, they kind of build up a little tolerance to the sedating effect. But antihistamines is the drug of choice. Really, the failure of antihistamines is when we're going to get into trouble, and we're going to go down the list. Now, the only treatment that's been actually shown in a randomized controlled trial to actually work for hives is cyclosporin. But we're not going to throw patients on cyclosporin. There's a lot of side effects, levels, that sort of thing. So usually allergists kind of go through this list, which unfortunately, is a little empiric, right? Because everyone's different and different things work for different people. But if we do make the decision to do cyclosporin, the allergist can handle that, and most of the time, patients respond very well to that medicine. So again, I'm going to just summarize the points. I'm basically at the end of the hour, so I don't have a lot of time for questions. But basically, you have chronic urticaria or acute urticaria. Is it urticaria, right? Make sure the rash is actually what you think it is. It's transient, it's itchy, it's raised, it's red. And as urticaria can cause by external exposure, but there's actually internal causes. I talked about autoimmune, the theories behind autoimmune triggers of hives. 6 weeks is your cutoff between chronic hives or acute hives. A lot of people get hives once in their life and then it goes away. The patients who are going to have continued problems over the years and years are the ones who are past the 6 week cutoff. Comprehensive allergy testing rarely leads to diagnosis. It should be directed by the history. And then antihistamines, really are the bedrock in treatment. And you might have to go up on the dose, like, sedating antihistamines 4 times a day, you might have to give pretty sizable dose of antihistamines to control these patients. Any questions? I did not. That's really good. So yes, there has been case reports showing efficacy of giving anti-IgE for urticaria. Thank you very much for mentioning that. The reason I didn't bring it up is because it's kind of hard to get approved. If they have coexisting asthma, sometimes that helps you out. But you're right. I think it's going to actually work very well. I'm very encouraged by the Perni studies. There's actually data looking at that, and I mentioned that in idiopathic anaphylaxis. But for routine use, I mean, like I said, some of these patients have lots of money. I mean, I guess they could pay out of pocket, but it's a very expensive medication. Like I said, most patients respond to antihistamines. Thank you. Are you awake? Still awake here? I mean, I feel sorry for you.